Obesity ANF Type 2 mellitus. Obesity constitutes a worldwide epidemic with prevalence rates that are increasing in most Western societies and in the developing world. By 2025, if this trend continues, the global obesity prevalence will reach 18% in men and exceed 21% in women. Furthermore, it is now well established that obesity, depending on the degree, duration, and distribution of the excess weight, adipose tissue, can progressively cause and/or exacerbate a wide spectrum of co-morbidities, including type 2 diabetes mellitus, hypertension, dyslipidemia, cardiovascular disease, non-alcoholic fatty liver disease, reproductive dysfunction, respiratory abnormalities, psychiatric conditions, and even increase the risk for certain types of cancer. See the chart, relationship between body mass index (BMI) and mortality, data from Kaye et al. NEJM 1999. In this video, we talk about obesity and type 2 diabetes mellitus. Source: https:/www.ncbi.nlm.nih.gov/books/NBK278973. Diabetes mellitus constitutes a rather diverse group of metabolic disorders which are characterized by hyperglycemia, e.g. type 1 diabetes, type 2 diabetes, gestational diabetes, maturity-onset diabetes of the young, drug-induced diabetes, diabetes secondary to pancreatic damage. Type 2 diabetes mellitus (T2DM) comprises up to 90% of all diagnosed diabetic cases in adults and is typically associated with the presence of various degrees of obesity. Depending on ethnicity, age, and gender, 50 to 90% of T2DM patients exhibit a BMI over 25 kilograms per square meter, while patients with BMI over 35 kilograms per square meter are almost 20 times more likely to develop T2DM compared to individuals with BMI in the normal range 18.5 to 24.9 kilograms per square meter for Caucasians. Indeed, T2DM rates have been increasing both in developed and developing countries following the documented prevalence trends of obesity, hence, the term diabesity has been introduced to describe this twin epidemic. Large-scale population studies have shown that obesity is the most important independent risk factor for insulin resistance and T2DM. In adults, the relative risk for T2DM begins to increase even at BMI values within the normal weight range, 24 kilograms per square meter for men and 22 kilograms per square meter for women, while it rises exponentially with increasing BMI over 30 kilograms per square meter. See the chart, body mass index (BMI) and risk of developing type 2 diabetes mellitus (T2DM) in male and female adults based on data from Kolditz et al. An Intern Med. 1995 and Chan J.M. et al. Diabetes Care 1994. Thus, morbid obesity is associated with a markedly high relative risk for T2DM in both genders, up to 90 and 40 for women and men, respectively. Although visceral adiposity is more prominent in men, obesity appears associated with higher T2DM risk in women compared to men. Moreover, T2DM increases the risk of CVD by 3 to 4 times in women and 2 to 3 times in men, after adjusting for other risk factors. Interestingly, impaired glucose homeostasis and T2DM have been linked to X chromosomal loci. However, the relative contribution of these loci to the onset of T2DM is not fully clarified yet. Overall, it appears that an interplay exists between gender, ethnicity, and certain adipose tissue characteristics which plays an important role in the association between obesity and related cardiometabolic comorbidities, including T2DM. Moreover, children and adolescents with obesity are now increasingly diagnosed with impaired glucose tolerance and T2DM. Furthermore, a strong association exists between central obesity and T2DM, beyond the impact of BMI. Both insulin resistance and hyperinsulinemia correlate positively to visceral fat accumulation, which constitutes an independent risk factor for T2DM. Accordingly, anthropometric indices of central obesity, e.g. waist circumference, waist-to-height ratio, and the visceral adiposity index, are utilized to better assess the obesity-related risk of T2DM and CVD. The higher cardiometabolic risk associated with central fat distribution is attributed to a combination of factors, relating mainly to a more deleterious adipocyte secretory profile in these fat depots. Indeed, visceral adipose tissue is more lipolytic, decreased insulin-mediated inhibition of the hormone-sensitive lipase and increased catecholamine-induced lipolysis, causing a greater flux of free fatty acids (FFA) into the portal circulation with lipotoxic effects primarily in the liver and skeletal muscle. Additionally, adipocytes in visceral fat depots exhibit increased secretion of pro-inflammatory adipokines, e.g. tumor necrosis factor alpha and interleukin-6, and decreased secretion of adiponectin, hence, leading to decreased insulin sensitivity and activation of pro-inflammatory pathways in the adipose tissue, liver, and skeletal muscle. Hormonal changes either at the systemic level of various neuroendocrine axes, e.g. chronic mild hypercortisolemia and dysregulation of the hypothalamic pituitary adrenal axis, as seen in chronic stress, or at the local level of the visceral adipose tissue, e.g. increased conversion of cortisone to cortisol via type 1 11-beta hydroxysteroid dehydrogenase, 11-beta HSD1, in fat depots may increase lipogenesis and thus contribute to adverse metabolic consequences of central obesity. It should be noted that insulin resistance in patients with obesity leads to chronic compensatory hyperinsulinemia, which in turn may promote further weight gain. On the other hand, it is interesting that acute and short-term increases of circulating insulin levels can even reduce liver fat accumulation, at least in mice. This concept may contribute to the documented beneficial effects of dietary protein and certain insoluble cereal fibers which induce a short-term surge in insulin secretion. Several studies indicate that both dietary protein and cereal fiber intake are associated with beneficial effects on blood glucose regulation and body fat distribution in the long term. With high-protein diets, this appears to be mainly related to increased satiety and weight loss. Intake of insoluble cereal fiber appears to improve insulin sensitivity and the risk of developing T2DM, with the only moderate weight loss involved unlikely to be the driving factor. Indeed, in an 18-week randomized controlled isoenergetic trial in 111 overweight or obese subjects, whole-body insulin sensitivity markedly improved with the intake of a diet high in cereal fiber. Interestingly, existing data also indicate that high protein intake in sedentary, at-risk subjects who typically fail to lose weight in the long term regardless of the diet could have adverse effects on insulin resistance and T2DM risk. Of note, Wang et al. Have investigated the metabolite profiles in 2,422 normoglycemic subjects who were followed for 12 years, with 201 of the subjects having developed T2DM. 5 branched-chain and aromatic amino acids isoleucine, leucine, valine, tyrosine, and phenylalanine showed highly significant associations with the future development of T2DM, with replication of the results in an independent, prospective cohort. The authors proposed amino acid profiling as a potential predictor for future diabetes, but a potential causal link between dietary protein intake and future diabetes cannot be excluded. Despite the widely claimed beneficial effects, there is increasing evidence that long-term high intake of both animal and total protein may have detrimental effects on insulin resistance, diabetes risk, and the risk of developing CVD. This could be especially detrimental in pre-diabetic subjects with obesity who already have impaired insulin secretion and may be resistant to the anabolic response to high protein intake, thus lacking several potentially important compensatory mechanisms for protein-induced worsening of insulin resistance. Furthermore, obese patients are typically sedentary, with potential additional unfavorable effects on protein-regulated mTOR S6K1 signaling and the development of insulin resistance, as suggested by studies in rodents. Finally, whereas elderly people with low protein intake may have detrimental effects, recent studies have linked high protein intake to cancer risk and overall mortality in younger individuals below the age of 65 years. Given this evidence, further research is clearly needed before high-protein diets should be widely proposed as a safe tool for weight loss in sedentary subjects. With obesity that typically fails in long-term weight maintenance after an initial diet-induced weight loss and is already at high risk of developing T2DM. Overall, in chronic hyperinsulinemia, a vicious cycle is formed, where fat accumulation causes generalized insulin resistance in adipose tissue, liver, and skeletal muscle, combined with increased insulin secretion and vice versa. Decreased insulin sensitivity in adipose tissue is crucial for initiating and fueling this vicious cycle. Normally, insulin-mediated inhibition of hormone-sensitive lipase in adipocytes decreases FFA release from fat depots, leading to lower FFA plasma concentrations, inhibition of hepatic glucose production, and increased muscle glucose uptake. However, in T2DM uninhibited lipolysis in insulin-resistant adipocytes causes persistently increased circulating FFA levels. In turn, this leads to reduced peripheral glucose utilization, increased hepatic glucose production and decreased insulin sensitivity in the liver and skeletal muscle. Thus, adipocytes play a crucial role in the overall regulation of glycemia in T2DM, although the adipose tissue glucose uptake is less than 5% of the total glucose disposal. In the liver, insulin regulates the hepatic glucose production rate by activating specific enzymes which induce glycogenesis and suppressing enzymes involved in gluconeogenesis. Hepatic insulin resistance can be defined as the failure of insulin to adequately suppress hepatic glucose production and is associated with fasting hyperglycemia in T2DM. Notably, the lipogenic actions of insulin do not appear to be compromised in insulin-resistant states, as will be further discussed in the following section of this chapter about obesity and fatty liver disease. Under normal fasting conditions, circulating levels of insulin are low, and fasting hepatic glucose production matches the basal glucose utilization, equal gluconeogenesis and glycogenolysis rates. In T2DM, the fasting glucose production in the liver is increased due to hepatic insulin resistance despite compensatory hyperinsulinemia. Overall, the absolute amount of hepatic glucose production is moderately increased in T2DM patients compared to that of healthy controls but is inadequately suppressed relative to the raised concentrations of glucose and insulin. This increased fasting hepatic glucose production exhibits a linear correlation with the degree of fasting hyperglycemia and is caused primarily by accelerated glucose synthesis through the gluconeogenic pathway. On the other hand, insulin resistance in skeletal muscle fuels postprandial hyperglycemia in T2DM, since skeletal muscles are responsible for most of the glucose disposal after meals. Decreased insulin sensitivity in skeletal muscles of T2DM patients causes impaired insulin-stimulated glucose uptake, which is both reduced and delayed. This postprandial underutilization of glucose by skeletal muscles is superimposed on increased hepatic glucose production rates, thus, compounding the magnitude and duration of postprandial hyperglycemia. Although necessary, insulin resistance alone is not sufficient for T2DM development, since the pancreas has the capacity to adapt by accordingly increasing both beta cell mass and insulin secretion. Due to these compensatory mechanisms, normoglycemia can be maintained despite reduced insulin sensitivity in the periphery. Thus, inadequate insulin secretion is a crucial component of the T2DM pathophysiology. Obesity contributes to beta cell decompensation and impaired insulin secretion through the related insulin-resistant state and various glucotoxicity and lipotoxic effects on the pancreas. Lipotoxicity can cause beta cell dysfunction depending on the degree of exposure to FFA and on the underlying genetic predisposition for T2DM. In vitro, prolonged exposure of beta cells to high FFA concentrations increases FFA oxidation and causes accumulation of intracellular metabolites, e.g. citrate and ceramide, which impair glucose-stimulated insulin secretion and promote apoptosis. On the other hand, pharmacological inhibition of lipolysis in non-diabetic individuals with a strong family history of T2DM can improve insulin secretion. Similarly, glucotoxicity can impair beta cell function depending on the duration and degree of hyperglycemia. In vitro, prolonged beta cell exposure to high glucose concentrations causes glucose desensitization, impairs insulin gene transcription, and induces apoptosis. Finally, it should be emphasized that both the insulin-resistant state in obesity and the related acquired beta cell defects can be restored, at least in part, with weight loss and good glycemic control. Indeed, several studies have reported that even modest weight loss, e.g. weight loss achieved by lifestyle interventions, including diet and exercise to increase physical activity, is important for T2DM prevention, significantly reducing the risk and delaying the onset of the disease. Like and subscribe channel to get notified as soon as possible when we have a new video. Thanks for watching.